Today I'm going to be discussing a study that I conducted regarding the perceived preparedness and comfort level of personal care aides when caring for patients with dementia in long-term care facilities. Dementia is a degenerative neurocognitive disorder that affects the population at large and in some instances is more debilitating than others. For instance, it may have an earlier onset in some cases than others, as well as cause more severe neurocognitive decline. When a patient has a severe case of dementia, this may place them in a long-term care facility. And in this instance, we have to focus on what training methods are the staff that are providing the direct care undergoing. And there's inconsistent training methods across personal care homes and nursing homes nationally. For instance, the federal regulations require personal care aides to undergo a 12-hour training program per year that contains a component regarding dementia care. However, this component is very variable at the state level in regards to what depth this component entails. Currently, there's no research that exists evaluating the perceived preparedness of personal care aides as they perform dementia care, which leads me to the research hypothesis: what is the perceived preparedness of a personal care aide as they're performing dementia care in residents of long-term care facilities? Our first hypothesis that we're going to cover today is that less than 50% will strongly agree that prior dementia training has prepared them to care for patients with dementia. Our second hypothesis is that at least 70% of our participants will have 4 or more years of experience. The third hypothesis is that there will be an increased preparedness seen in those who have undergone formal dementia training in the past versus those who have undergone no formal training in navigating a confusing episode of a dementia patient. The fourth hypothesis is that less than 25% will agree or strongly agree that they are prepared using a person-based approach to dementia care. And the last hypothesis states that less than 40% will strongly agree that they are prepared to navigate an autonomous decision-making of a dementia patient. Our sample included personal care aides at a personal care home in Bradford County, Pennsylvania, and the sample size was very small and therefore limits generalizability. And additionally, the survey was conducted as a paper survey that was administered within the facility and collected in a collection box in a general vicinity within the personal care home. And this paper survey was used to promote compliance. And the study also assumes that all personal care aides have had some sort of prior dementia training, along with our answering the questions with transparency and honesty. Our chapter 2 discusses some pre-existing literature that exists regarding dementia. And first off, let's discuss the burden of disease. As we said, the incidence of dementia is projected to increase due to the increasing lifespan of people. More specifically, in 2019, there was 57.4 million individuals that had dementia, and by the year of 2050, the prevalence is expected to increase to 152.8 million people, so more than double in the upcoming years. Ethical dilemmas arise in dementia care in regards to drawing a fine line between when the patient is able to make decisions on their own or when we need to promote decision-making from advanced derivatives and or a surrogate decision maker. Financial constraints are placed on the patient and the family due to the fact that dementia is a neurodegenerative cognitive disorder that cannot be treated. So it is managed with pharmaceutical measures throughout the duration of the patient's life, which could potentially cause financial constraints on the patient and the family. Additionally, in some instances, like we mentioned, patients with dementia have this debilitating disease that requires them to be admitted into a long-term care facility, which can also cause financial constraints as well. It has been seen that long-term care facilities do not have the proper funds to implement training programs that will provide the dementia patient with the utmost quality of care for the remainder of their life as well. When we discuss a little bit about the policy that exists about dementia training and the reality of providing dementia care, we see that The federal regulations as well as the state regulations cause very variable training programs at large. And essentially these programs are more centralized on definitions regarding dementia and less about the person-based approach, which is significantly promoted in caring for patients with dementia, an individualistic method to care for each patient that has dementia. Additionally, as prevalence rises globally, there's increased pressure on the personal care aide. More specifically, personal care aides are the ones responsible for 70 to 80% of direct care to dementia patients in long-term care facilities. In this way, sometimes increase of workload is resulted from short staffing as well as the increased prevalence of dementia seen in these long-term care facilities. It has been noticed that personal care aides have a difficulty in navigating behavioral outbursts as well as communication barriers related to the symptoms of dementia. Holton's model is a model that says you must have an essential and a foundational knowledge in dementia care along with experience in order to have the utmost comprehension about caring for patients with dementia. Some of the evidence-based approaches to care that should be noted are the person-based approach. Like we said, it is an individualistic approach to care for each patient that has dementia along with the symptoms that are specific to that patient. Additionally, the person-based approach says that dementia serves as a component of that personality and does not define that person as a whole. Hands-on approaches to care is also supportive of Holton's model, where we reinforce that foundational basis of education and knowledge with hands-on experience in order to provide the utmost understanding and comprehension about dementia care. Non-pharmacological treatment has also been seen as beneficial in these patients with dementia. For instance, music therapy tends to sometimes calm down patients with dementia in certain instances, along with things like activities regarding puzzles or exercise, anything to really keep the patient's mind busy. With these concerns in mind, I've developed a study that is a quantitative cross-sectional study that involved 20 personal care aides from a personal care home in Bradford County, Pennsylvania. All of these paper surveys were anonymous and all of the participants were not compensated for their participation. The survey was ran from June 21st to June 25th of 2025, and the purpose of this study was to evaluate the perceived preparedness and comfort level in dementia care of these personal care aides. The structure of the study included 15 quantitative questions along with 1 qualitative question. The methods that we used involved proportion tests, so we did a 1 proportion z-test along with a 2 proportion z-test, and we also ran Likert scale analysis to analyze mean values regarding each question of the survey. The topics that were involved in the analysis were questions regarding autonomy, questions regarding the managing symptoms of dementia care, along with prior experience, whether the person had a history of formal training, along with whether or not these personal care aides were able to use a person-based approach to care. Now we're going to look into the results to see if the results from this study at the local level support pre-existing literature at the national level. Our demographics. So the participants in this study were mostly age 18 to 25 years old. Specifically, 45% of our participants were 18 to 25 years old, very new in the area of healthcare. 55% of our participants had only an education level of a GED or high school diploma. 35% of our participants only held 0 to 3 years of experience, and 50% of the participants claimed that they have at that point had no prior dementia care training. When we look at our first hypothesis that less than 50% of our participants will strongly agree that prior training programs have prepared them to care for patients with dementia, we actually seen that 10% strongly agreed that they were prepared by these prior training programs. And therefore, we ran a 1 proportion z-test to determine a p-value of 0.0017, which was actually less than our standardized significance value of 0.05, and therefore we can say that our result of this was significant, and therefore we can reject the null hypothesis and accept the alternate that in fact less than 50% strongly agree that they were prepared by prior training programs. Our second hypothesis stated that at least 70% of participants would have 4 or more years of experience, and actually only 55% had 4 or more years of experience. A 1 proportion z-test was ran to determine that a p-value of 0.12, which was not less than our standardized significance value of 0.05, and therefore the result of this is not significant, and therefore we cannot reject the null hypothesis, and we do not have evidence enough to support that our alternate hypothesis, in other words, at least 70% had 4 or more years of experience, cannot be supported. We look into the perceived preparedness from experience levels using percentages, and it was found that 70% agree that they are prepared from prior experience in the field of dementia care, 20% strongly agree experience contributed to preparedness, and 10% of our participants remain neutral on the matter. Hypothesis 3 said that there would be an increased preparedness level in those who have undergone formal training versus those who have not undergone any type of formal dementia training in the navigation of a confusing episode of a dementia patient. 90% of the formally trained and 70% of the individuals who held no training claimed that they were prepared in navigating a dementia patient having a confusing episode. Therefore, we ran a 2 proportion z-test to find a p-value of 0.132, which was not less than our standardized significance value of 0.05, and therefore the results of this test were deemed insignificant, and therefore we cannot reject the null hypothesis, and there is not enough evidence to support the fact that those who have undergone formal training are more prepared than those who've had no formal training at all. We evaluated the perceived preparedness from prior training programs in the personal care aids using percentages and found that 45% strongly agree that prior training programs have prepared them in the field of dementia. However, that was also matched with 45% of our participants having a neutral stance on the matter. Hypothesis 4 stated that less than 25% would strongly agree that they are readily able and prepared to use a person-based approach to dementia care. Actually, it was found that 85% of our participants feel prepared using a person-based approach to care, and a 1 proportion z-test was ran to find a p-value of 1.0, and this was significantly greater than our standardized 0.05, and therefore we deem the results of this test not significant, and we cannot reject the null hypothesis, as well as there is insufficient data to support that less than 25% are prepared in the field of dementia care to use a person-based approach. Our last hypothesis, hypothesis 5, stated that less than 40% of participants would strongly agree they are prepared in autonomous decision-making when caring for a patient with dementia. It was actually found that only 15% believed that they could navigate autonomy. Therefore, a 1 proportion z-test was ran, and it was found that a p-value of 0.011, which was significantly less than our 0.05 p-value, or significance value rather, and therefore our null hypothesis was rejected, and we can definitely accept our original hypothesis that less than 40% of participants would be prepared to use autonomous decision-making in patients with dementia. Likert scale analysis was used to evaluate mean values regarding each question of the survey to kind of get a more holistic viewpoint from our population at large. The Likert scale analysis is evaluated on a range from 1 to 5, 1 claiming strongly disagree, and 5 claiming strongly agree. When analyzing these results, if the question scored a mean value greater than 4, this would indicate maximum preparedness in the area. If the score was 3 to 3.9, this would indicate moderate preparedness, and a mean value of less than 3 would indicate low preparedness. Areas using the Likert scale that scored high preparedness were areas like ADLs, so personal care aides felt amply prepared to navigate activities of daily living, such as bathing, dressing, grooming, medication administration. Also, our personal care aides claimed to be prepared in areas such as using a person-based approach to care. So, caring for patients with dementia individualistically and using a tailored approach to each specific patient. Also, individuals claim that they are amply prepared to navigate behavioral outbursts of patients with dementia. Questions on our survey that scored a moderate preparedness level include navigating communication barriers, so personal care aides feel sort of prepared to navigate the communication difficulties between them and the dementia patient, as well as navigating autonomy, so determining when or not the patient is able to make a decision for themselves. And also, they scored moderate preparedness levels in areas of behavioral change related to dementia. The Likert scale was also used to evaluate the perceived support from the facility to the personal care aide. And what was found is that personal care aides feel moderately supported by their facility with a mean value of 3.5. This means 60% were satisfied with the support given by the facility in the area of dementia care, but that also leaves 40% that were dissatisfied by the support from the facility. With a mean value of 4.2, very significant, personal care aides as a whole would feel better prepared using more implementation of dementia training programs within this facility. And this result indicates that personal care aides recognize the gaps and the barriers of dementia care in knowledge, and they are willing to take the stride in order to better themselves and make themselves more knowledgeable in the field of dementia care to provide the utmost care to patients. To cover a summary of significance of our proportion tests, what was significantly found was that training programs are inadequate to prepare personal care aides to navigate decisions related to dementia care. Also, the navigation of autonomy served as a difficulty for personal care aides. But on the other hand, the results that were not significant were that our participants most of them would have 4 or more years of experience. We realized that most participants were very young in the field of healthcare with only 0 to 3 years of experience. Also, most personal care aides were very readily able to use a person-based approach to care, which was not analogous with what we originally predicted. And also, there isn't a significant difference seen between those formally trained and not formally trained in the navigation of a confusing episode of a dementia patient. Our discussion will highlight strengths and gaps as well as compare our results to pre-existing literature. What we found in our study, as is analogous with pre-existing literature, is that training programs are inadequate. In our study, we found that 10% strongly agreed that they are prepared by formal training programs, which could be attributed to the pre-existing literature that highlights that training programs only enhance that basic definition of dementia and is less centralized on the person-based approach to care. Additionally, experience does not equal competence, and this was seen when we found that those who have had prior experience did not find it easier to perform dementia care. For instance, 70% of our participants had less than 4 years of experience. That is what we claimed. What we found was that only 55% had 4 or more years of experience. And on another note, what we found was that our personal care aides are amply prepared in a person-based approach to care. So 85% feel prepared to use this individualistic, person-based approach. This supports the hopes of the Tumor Consortium on Living, which states that there must be communication between the patient and the direct care worker as well as their provider to come up with an individualistic and personalized care plan that allows them to have the utmost quality of care. Some of the ethical challenges in moving forward. Our results showed that navigating autonomy is a significant barrier that we see in personal care aides when dealing with patients with dementia. And this is analogous with prior studies as well. For instance, D. Cruz had a rationale of a gray area regarding a situational basis of care. And this is essentially highlighting the fact that we must enable the patients to use autonomous decision making, but we must have a situational judgment to balance beneficence and non-maleficence. In other words, how do we allow the patient to make their own decisions, but also do the most good without doing the most harm? And this is a barrier that is seen in the personal care aides when navigating dementia care. As our Likert scale analysis said that personal care aides are amply prepared to perform activities of daily living, there was also areas that needed improvement that were seen as a result of the Likert scale. For instance, behavioral challenges, which are parallel with pre-existing web-based survey literature that exists. Behavioral challenges seem to be a significant barrier for direct healthcare workers, as well as our personal care aides would feel better supported by their facility if they implemented further dementia care training programs. What I learned from this study was that in order to have the most holistic comprehension of dementia care, you must have components of experience as well as components of foundational education. And I was very shocked that without both of these components, you will not have the most competence in the area of dementia care. I was also very shocked about how difficult personal care aides are at navigating autonomous decision making. And if I was to conduct this study again, I would change my paper survey to an online web-based survey to allow statistical analysis to be easier and more efficient per se. And additionally, I would include a larger sample size so that the results of this study would be generalizable to other populations. And in conclusion, my hope with this study is that it highlights the gaps that need to be abridged within this small personal care home in Bradford County, Pennsylvania, but also provide insight to futuristic studies at large. Thank you for listening.